Welcome. In this session, we're going to discuss key management guidelines, and we're going to try to actually provide a path that you can follow in management of the foot and nail client. So we want to start with this concept of levels of care. This was first introduced by the foot and nail care nurses at the Medical University of South Carolina. And we include it because we think it's very helpful to those of you who may be working in home care or in a large agency where there's no way you can see everyone who needs foot and nail care. This might even be relevant in a large outpatient clinic where you see a lot of clients with different levels of complexity in terms of their care needs. So the basic concepts underlying this levels of care model are that practitioners have different levels of knowledge and skill and expertise. Patients have different levels of clinical needs. Some patients need just assessment and education and maybe minor assistance, and others have very complex foot and nail problems. And so the goal is to match the practitioner's level of knowledge and skill with the patient's level of need. And so they divided foot and nail care into literally 3 levels of complexity. Level 1 care, any nurse should be able to provide. It's going to say RN, but actually an LPN could easily do this level of care. So level 1 care, the patient has intact skin, they have intact sensation, their perfusion is essentially normal, palpable pulses, no evidence of ischemia, and relatively normal nails. Now, their nails might be a little thick, a little long, but bottom line, perfusion's good, sensory motor function's good. So they need screening assessment, basic education, and possibly some assistance with actually trimming the nails. Again, RN, LPN. So what interventions would be required at this level? Typically, clients only need to be seen once a year. These are people who can basically do their own nail care. Once a year, you're going to carry out that screening. What does their perfusion look like? What's their sensory motor status? What about skin status? What about nail status? Looking at their footwear, comparing their footwear to a Tracy. And the primary focus, assessment, education, okay? Your feet look good, what you're doing is right. I noticed that, you've got some wear patterns in your shoes, probably need to get your shoes replaced, etc. Now, level 2 and level 3 care are going to require a higher level of expertise, and that's where you would come in as a foot care nurse. Now, at level 1, you would probably just be teaching other nurses in your clinic. These are the critical elements of a screening assessment. These are the things you want to be teaching patients. For patients who are diabetic, even more important to make sure that they're coming back every year for their screening assessment, that they know indications of problems. If they start to see callus formation, if they start to see corn formation, anything like that, that they call us back and get in here. Beyond level 1, they're going to need you. So who falls into level 2? Level 2 patients have palpable pulses, so the indicators are that their perfusion's okay. They may have neuropathy, so you may see alterations in sensory function. They may fall into the category of loss of protective sensation, where there are 4 or more sites where they do not respond. They might have some skin complications. They might have callus formation, corn formation, maybe a fungal infection. They might have long, thick nails. So what do they need? They need assessment, they need education, but they also need a higher level of intervention. So they need someone who can thin and trim their nails and buff or repair corns and calluses. So what's the level? Typically RN with special training. In some states, LPN with special training. So anyone who's completed a foot and nail course and has obtained certification would certainly meet the criteria for level 2 care. If you are not advanced practice, you may or may not need an order from the physician. It depends on your care setting. So if you go to, say, an assisted living facility and the patient contracts with you directly, they're like, I'll pay you this much to do my nail care. No, you don't need an order from a physician. But if you're working in an outpatient clinic and some of these charges are being passed on to insurance or Medicare, yes, you need an order. So that just goes back to care setting. Advanced practice nurses definitely qualify for level 2 care. So what do these patients need? They should be seen at least 3 times a year, every 4 months. You're going to be doing your screening assessment, monitoring them in terms of perfusion, monitoring them in terms of sensory motor status. You're going to be thinning and clipping the nails, managing corns and calluses. Typically at for level 2 clients, the calluses and corns are non-painful and relatively thin, so usually you can just buff them out. And you're going to be providing education about footwear and foot care. Level 3 is the most complex. Clients who fall within level 3 frequently have diminished perfusion, so they may have only faintly palpable pulses or non-palpable pulses, low ABI. They may have loss of protective sensation. They may be insensate. They frequently have skin and nail problems, and they frequently have foot deformities. What do they need? They obviously need very frequent assessment because they're very high risk. So we do not want them to get into trouble. We are trying to keep them out of trouble. We're trying to prevent lesions that could progress to amputation. They need intensive education as to the importance of daily foot inspections, never, ever, ever, ever going barefoot, promptly reporting any problems, any issues so they can be managed. At level 3, you're doing a lot to correct nail problems and skin problems. So you're paring corns and calluses, you may be dealing with ingrown nails, you may be thinning nails, etc. And you may be referring them for appropriate footwear. So again, who qualifies for level 3 care? Only nurses with special training. So your foot care nurses, it could be expanded role, specialty practice, or your advanced practice nurses. But the bottom line is, even if you're advanced practice, you wouldn't take care of these clients unless you had additional education in foot and nail care. Our bias is that if you're providing level 3 care, you really should be certified as a foot care nurse. That protects you as well as the client. Here you want the patient coming back every 3 months and PRN. You're doing ongoing assessment, intensive education, and all levels of nail care. So there are specific problems that need to be managed at level 3, and we're going to go through these. So fungal infections are one. We see a lot of fungal infections, skin infections, and nail infections. And you should be able to recommend appropriate over-the-counter products, or for a patient with a refractory fungal infection, a patient with a very symptomatic fungal infection, you should refer to either a podiatrist or to their prescribing physician or NP to get systemic agents. At level 3, you should be prepared to manage ingrown nails, which involves lifting out the ingrown nail, clipping off the portion that's digging in, smoothing the edge, and frequently doing a little bit of packing, which we'll come back to. Now, we're going to talk a little bit about professional practice issues. There's always a lot of questions because this whole foot care nurse role is relatively new, and there's a lot of questions about it. Probably many of you can remember being taught in nursing school not to touch nails. I still talk to nurses who were taught, don't touch their nails, just tell them what to do. And you know, Rose and I laugh because we remember how we got started in foot and nail care. My earliest exposure to foot and nail care, I have to tell you, was when I was teaching in a 2-year program, taking students to a local community hospital. And this woman comes in and she has those ram's horn nails that go way, way, way out. And so I said to the nursing staff, I was not a foot care nurse, I didn't know anything about foot care. But I knew she couldn't wear shoes and that she couldn't walk normally and something needed to be done. So I said, what are we going to do about her nails? And they're like, we're not going to do anything. I'm like, no, we've got to do something about her nails. So do we refer to podiatry or what? No, we don't have a podiatrist. We're not going to do anything about them. That's not why she was admitted. So I sent my students on break. I said, take a long break. And when you come back, if the door is closed, don't come in. That way you won't be involved in anything illegal. I went and got a cast cutter and a tray from the cafeteria. Now, orthopedics want to know why I wanted a cast cutter. I'm like, you don't need to know, best you not be involved. Sat her up in the chair, put her nail on the tray, on this hard plastic tray. So her toe was not on the tray, just her nail. And I'm like, Miss So-and-so, I want you to sit real still because I'm going to cut off this nail. She's like, honey, I'm not about to move because that thing's making noise. I had the cast cutter. So I literally took the nail off. I left about ½ an inch, 3/4 of an inch beyond the toe. So I wasn't putting her at risk. But I got enough of it off that then we could use emery boards to, progressively file it down. So then the nurses were like, what happened to her nail? I never admitted anything. But the bottom line is, nail care matters. Taking care of feet, taking care of nails, helps keep people out of trouble, and that's our goal. So you want to know exactly what the guidelines are in terms of what can you do legally, can you bill for services, can you get reimbursed, that kind of thing, and that's what we're going to go over now. So let's talk about licensure and scope of practice. Obviously, you have to be a licensed healthcare provider to provide foot care, especially at levels 2 and 3. It is dependent on your state board of nursing. So as you probably already know, nursing practice in each state is governed by that state's board of nursing. LPN practice, RN practice. Now, in most states, the language is very vague and basically lays out what you're expected to do in terms of assessment and interventions and evaluation. And then usually there's this clause that says, and performs other procedures for which you have been trained. That covers you because they don't want to do a laundry list of things nurses can and cannot do. It's too exhaustive. However, state boards of nursing differ, and you do not want to find out that you are practicing in a manner that is contrary to your licensure. So the best thing to do is to contact your state's board of nursing, explain to them that you have taken a foot and nail care course that was provided for healthcare practitioners, that you are planning to obtain certification as a foot care nurse, and that you want to make absolutely sure that you document everything that you need to document in order to be covered by your state Nurse Practice Act. So check it out on a state-by-state basis. We believe that it will be extremely helpful to you to obtain certification as a foot care nurse. It speaks to your knowledge level, and in many states they require some proof that you have obtained additional education. Certification certainly would meet those criteria. What about reimbursement? Can you bill for these services? So I would say the best answer to that question is, in general, no. And then let me explain the situations in which you can bill. So I'm going to tell you first where you can't. Home care, will you get additional payment if you provide foot and nail care? No. acute care, hospitals, will you be able to obtain additional payment if you provide foot and nail care? No. The two settings in which reimbursement may be available for some clients is in the outpatient setting and in the long-term care setting. However, it is not universal. Patients have to meet the criteria for having nail care done professionally. And basically what Medicare, other third-party payers are saying is, we are not going to pay for nail care that could be safely provided by the patient or his or her family. So it's not enough even to say, well, the patient's diabetic. You have to be able to document that they have complications from the diabetes that would make it unsafe for a non-skilled provider to provide their nail care. So if you have a copy of the booklet that you obtained along with this course, I think we gave you some of the language, and I'm going to that language now to make sure I don't mess it up. So one example is type 2 diabetes with peripheral arterial disease compromising skin integrity and placing the patient at risk for injury and infection if nail care is provided by a non-skilled provider. If you talk to podiatrists, if you note their documentation, that is what they consistently document. Not enough to say the patient's had type 2 diabetes times 10 years. You have to document the complication associated with diabetes that makes it unsafe for a non-skilled provider to do the foot and nail care. Do they have to be diabetic? No. What if I have peripheral arterial disease unrelated to diabetes? I qualify for foot and nail care provided by a podiatrist or a certified foot care nurse, and third-party payers in general will cover that service. So first of all, you have to either be in outpatient care or in long-term care. Secondly, the patient has to meet the medical criteria, which means there is a medical condition that makes it unsafe for foot and nail care to be provided by an unskilled provider. And thirdly, you have to meet the specific criteria for payment established by that third-party payer. Now, almost all of your patients will be Medicare, so I'm going to focus on Medicare. If you are an advanced practice nurse and you have your own UPIN number, your own unique provider identification number, and you are working in an outpatient clinic, I come in, I'm diabetic, I have coexisting peripheral arterial disease. You can provide the care, you can bill for the care so long as you document my peripheral arterial disease, evidence of my peripheral arterial disease that makes it unsafe for someone else to provide my foot and nail care. So I've commonly seen podiatrists document this, patient exhibits, elevational pallor, dependent rubor, diminished temperature, absence of hair, thin shiny skin, diminished pulses, ABI of 0.6, all consistent with peripheral arterial disease. Because of peripheral arterial disease, patient requires professional nail care to reduce the risk of infection and limb loss, or something to that effect. So if you're an advanced practice nurse working in an outpatient clinic, can you bill for this service? Yes, so long as you're billing under your UPIN number and you document the medical necessity for this care. What if you're advanced practice in long-term care? Well, same thing. You can go into a long-term care facility. You can market to the long-term care facility. Podiatrists do this all the time. That you can come in, you can provide foot and nail care to their residents. But only the residents who have peripheral arterial disease will be eligible for reimbursement from Medicare. So there might be 20 residents who need foot and nail care, and maybe only 5 of them meet the criteria for medical necessity. So you're going to have to do another approach to billing the 15 who have no medical reason for foot and nail care. I know it's confusing. We'll be glad to answer any questions, but it basically goes back to there has to be a medical reason for that individual to receive professional level foot and nail care. Okay, so in APRN, with your UPIN number, you can bill in the outpatient setting through the agency, or you can go to long-term care and you can bill Medicare directly. Well, what if you're an RN, you're a certified foot care nurse, but you're not advanced practice? Then you can only bill if you're working under medical supervision. This is how that works. I am an RN. I am not advanced practice. I am certified in foot and nail care. I am working in an outpatient center. It's an outpatient skin wound ostomy center. We also provide foot and nail care. Mr. Jones comes in. Mr. Jones has diabetes. He has peripheral arterial disease, etc., etc. We provide his nail care every 3 months because of his peripheral arterial disease. Okay, can I bill? Yes, because he meets the criteria for medical necessity. So my clinic can bill for his care. I can provide the care, and those charges can be filed through my clinic. But I have to meet the criteria for medical supervision. This is what Medicare says. Medicare says a non-advanced practice nurse can provide critical care, can provide the needed service, can bill for that service so long as it is provided under the direction of a physician or an advanced practice nurse. So as long as there is a physician in the clinic, or at least readily available to the clinic, or a nurse practitioner. So let's go back through that again. I'm a non-advanced practice nurse working in an outpatient clinic. The patient comes in, meets the criteria for medical necessity. Yes, we can bill for that care that I provide. But I can bill for that care only if I meet the criteria for medical supervision, which means I have a physician or a nurse practitioner who is available to me should I need them. Do they have to be standing there by my side? No. They can be down the hall in another room. They could be across the hall in another room. A physician could be making rounds. The physician cannot be in surgery or interventional radiology or tied up in the emergency department. They have to be available to me. So it's more difficult if I am not advanced practice. It means that I can only bill in the outpatient setting if I have a physician or a nurse practitioner providing medical supervision and if the patient meets the criteria for medical necessity. What about me going to long-term care? I do not have a provider number, so I cannot bill Medicare directly. The only way I could ever make that work is to team up with a physician or a nurse practitioner. We would both go to the center. We would do initial rounds. Then the physician would leave me, or the physician or the NP would leave me to do a certain number of patients while he or she went to do the other patients. All billing would be done by the physician or the NP, and then they would pay me. So you can see there's not a lot of opportunities for reimbursement. Remember that the biggest exclusion is that you can't bill for nail care provided just because this patient has arthritis and can't get to their feet. You can't bill for nail care because this patient's morbidly obese and can't get to their feet, or legally blind and can't see their feet, because the stance is, okay, we get it, the patient can't do his or her own nail care, but a family member could safely do their nail care. Nail care for most individuals is hygienic. It becomes skilled care that should be provided by a qualified nurse or physician only for patients who have medical comorbidities that make it unsafe for a non-skilled individual to cut their nails. If that doesn't make any sense to you, call and we'll try to explain it. So, principle number 1, reimbursement is very, very limited. When you think about the fact that you can only bill for patients who meet the criteria for medical necessity, add to that only advanced practice nurses or nurses working under the supervision of a physician or NP can bill, and only for patients who meet the criteria for medical necessity, and only in the outpatient clinic or long-term care. You can see that reimbursement is extremely, extremely limited. So, should you be thinking, forget it? No. Is there payment? Yes. But it is a fee-for-service model. Most of your payments will be fee-for-service. So how would that work? You might go to an assisted living facility. You might go to a skilled nursing facility. And you might say to the residents of that assisted living facility, to the families of the residents in the skilled nursing facility, I'm a certified foot care nurse. Here are the services I can provide. I come to this center twice a month, or once a week, or whatever. Here is my fee schedule. Then they can pay you directly. You provide the service, they pay you. And I should just briefly mention that when you're setting up your fee schedule, don't underestimate your value. There are 2 key principles to take into consideration when you think about setting up your fee schedule. First of all, you have to be competitive in the region. So call and ask in a podiatrist office, call several podiatrist offices and just say something like, you know, my mother can no longer do her own nail care, and I wanted to see how much it would cost if I brought her to your office to get her nail care done by the podiatrist. And they'll tell you. So you want to know how much podiatrists charge, and you want to know how much nail salons in your area charge. You're going to provide a much higher level of service than the nail salons. You're going to be able to do things that they can't do. And you're going to, in general, provide much more attentive, patient-focused care than the podiatrist, who doesn't really like cutting nails. That's not what they want to do. That's not what they went to school for. I want you to realize that if I am taking my mother to get her nails done, and she does not have any condition that meets the criteria for medical necessity, if I take her to the podiatrist to have her nails done, I will be paying out of pocket. The podiatrist will charge me, I will pay. So I have to take her there, pay, bring her back. If I take her to the nail salon, I take her, I pay, I bring her back. If you come to that assisted living facility or skilled nursing facility, that makes it much easier for me. I feel really good because you're a certified foot care nurse. I know you know what you're talking about. So you are competing with the nail salons and the podiatrist. You'll provide a higher level of service than the nail salon and a more patient-focused service than most of the podiatrists. Don't sell yourself short. The second thing to think about is that approximately half of what you bring home will go to self-employment tax. So if you're thinking, well, I want to bring home at least $40 an hour, then you're thinking, okay, well, I need to bill at least $80 an hour. And maybe I'll shoot, because I'm going to have some expenses, so maybe I'll shoot for bringing home 50 an hour, so I'm billing 100 an hour. So you're thinking nobody's going to pay 100. Well, we're not done yet. On average, you can do foot and nail care, a very good job for a client within 30 minutes, unless it's their first visit. So their first visit might take 45 minutes, and that might be billed at a higher rate. And then subsequent visits might be billed at, say, 45 to 50. So if you see 2 clients in an hour and you're charging 45 to each, you would be making $90 an hour, which translates to you to 45. Does that make sense? I hope you're following this math. So let's go back to the 2 key factors to consider when you're setting up your billing schedule, your fee schedule. Take what you want to make an hour, double it. That becomes your hourly rate. Then, for a service that takes 30 minutes, is projected to take 30 minutes, it would be half of that hourly rate. So if altogether my hourly rate's 90, and I'm scheduling you for a 30-minute slot, it's 45. If I'm scheduling you, let's say I'm billing 100 an hour, I'm scheduling you for 45 minutes for your initial visit, it's going to be 75. And then subsequent visits might be 50. Okay, I'm hoping that makes sense to you. Go back to the fact, people pay out of pocket for nail care. There are nail salons everywhere. They're not doing what you're going to do. So there is a need, there is a service that you can provide at a high level that's going to make people very happy. So don't sell yourself short. You would want to meet with a CPA to set up your bookkeeping system so that you know what you're billing, what you're bringing in, etc. Okay, a couple of other professional practice issues I wanted to go over before we walk you through the pathway for actually providing foot and nail care. Infection control is, of course, a huge issue. You're going to follow universal precautions. So what does that mean? That means I always have clean hands before I touch your feet. It means that if I have any lesions on my hands or you have any lesions on your feet, I have to wear gloves. If you have intact skin and I have intact skin, gloves are optional. I know some foot care nurses who always wear gloves. I know other foot care nurses who wash their hands very thoroughly and wear gloves only if there's a lesion, either on their hand or on the patient's foot. So universal precautions. If you use a rotary drill, like a handheld drill to thin very thick nails, you of course have to have a mask and shield whenever you're using the rotary drill. There are little vacuum devices that you can use in conjunction with the rotary drill to reduce the amount of aerosolized dust. I have not seen any studies that address their efficacy. How effective are they? I don't know, but I do know that those are out there. Bottom line, we want you to know that at this point, the use of a handheld drill to thin those very thick nails is controversial. There are some foot care providers who never use them. There are other foot care providers who always use them. We don't have enough data to say you should not use them. I also do not have enough data to say absolutely don't worry about it. So this is what we say to you. If you're using a handheld drill to thin thick nails, make sure that whenever you're doing that, you are wearing a mask and a shield so it doesn't get in your eyes or in your nose. And if you come here to do your clinical, you will see that we are using rotary drills, but I will tell you that other centers do not. Okay, let's look at management of your equipment. Now, this is a huge issue if you end up going into practice for yourself, going to an assisted living, skilled nursing, whatever. You basically have several options. You can either do cold disinfection with Sidex, which involves washing the instruments thoroughly, drying them, and then doing a Sidex soak according to guidelines. Now, Sidex, as you know, is cytotoxic. The recommendations are that if you're using Sidex for cold disinfection, you do it under a hood so that you're not exposed to the vapors, and obviously that you use gloves when putting instruments in and out. Sidex is widely used in outpatient clinics, so if that's where you are, yes, that's a very appropriate way of disinfecting the instruments. What's another option? Well, if you're in a healthcare setting, if you're in a hospital and you're going to add this to your services, even though you know you won't get additional reimbursement, you can send the instruments down to be autoclaved. Same thing if you're going to a skilled nursing facility, they may have the ability to autoclave. But what if you're doing fee for service and you're going to this assisted living facility? Then our recommendation would be purchase enough sets of equipment to do the number of patients you plan to do within one visit. So let's say I'm going there on Saturday morning and I'm planning to do a total of 6 visits. Okay, then I need 6 sets of equipment. When I come back, I can wash those instruments very well, dry them, and then I can either boil them in boiling water, remember that's what we used to do, for 10 to 20 minutes, or I can put them in the dishwasher. That is going to sterilize anything. So I can either use boiling water or the dishwasher. So if I was going to do that, what I would do is I would take each set of instruments and I would put them in a Ziploc bag, and I would have my Ziploc bags labeled, okay? Set number 1 clean, set number 2 clean, so I'd have 6 little Ziploc bags. And then I'd have a large Ziploc bag for dirty instruments, and it would be labeled. And when I finished with client number 1, I would take those instruments and I would put them in my Ziploc bag for dirty instruments. So you can make it work and you can keep it simple. You don't necessarily have to have very expensive equipment. You want to be safe, you want to keep your clients safe, and you can do so with pretty simple strategies. We are going to recommend doing brief soaks for your clients' feet. It makes it wonderful for them, much nicer for you, but more importantly, you're going to find that that brief soak softens the nails, softens the cuticle, makes it very easy to scoop off excess cuticle, makes it easier to clip the nails. Many reasons to do a brief soak. Okay, but then that involves equipment. So we typically use the Rubbermaid, what do you call them? Tubs, rubber tubs, okay, for soaking feet. And you have a couple of options. One, you can actually get disposable liners that are just thin plastic liners, and then you can just throw it away. Or you can take kitchen-sized garbage bags and use those as liners and throw them away. Or the other thing you can do is, after you've used the tub, you can rinse it out very well. You can dry it completely. You can soak it with Lysol spray. So you get Lysol that is antibacterial, antifungal, antiviral. You wet all surfaces and you allow it to air dry. We actually had all of these procedures checked out by our infection control department. And we've actually been doing that for a number of years with no issues with infection. Okay, so we've talked about infection control issues. I should also mention that because we do use rotary drills, we do have antiseptic impregnated towelettes that we can use to wipe down the drill. And we actually use stainless steel drill bits. And the drill bits are we either do cold disinfection with Sidex, or we boil or autoclave. So we clean them exactly the same as all of our other stainless steel instruments. Now I'm going to walk you through the pathway that we recommend for actually providing foot and nail care. And if you come here to do clinicals, you'll see us following this pathway. We do recommend a brief soak. Now, we know that the current guidelines say never do soaks for diabetic feet. But we also know that that recommendation is based on concerns that overhydration can lead to spontaneous fissure formation, especially if the patient does not dry between their toes, and that patients with sensory neuropathy may fail to check to be sure the temperature is okay and may get a burn. As the provider, we can control both of those issues. So we can control temperature and we will dry between the toes. We've already talked about the benefits of doing a brief soak. It makes it like a spa visit for the patient, so it's wonderful for the patient. But more importantly, you start out with clean feet, softer nails, and very soft cuticle. So we believe it makes a big difference in providing safe, effective, comfortable foot care. So a brief soak, we just do warm water with a little bit of very mild soap. You could do plain water. If you are not in a position where you can do soaps, you could always do disposable cleansing wipes and just wipe down the foot. Wouldn't feel as good, doesn't work as well, but it is an option. Okay, so I've gotten them out of the soak. So what we do is we put them in, we let them soak for about 10 minutes. We take them out, dry their feet off, dry between their toes, leave them wrapped up in a towel. Take the tub, empty it, rinse it thoroughly, dry it thoroughly, soak it with the Lysol, leave it to dry, come back to our client. Now I'm going to do that brief assessment. This is a follow-up visit, so I'm not doing a comprehensive assessment. We start at the knee, we come down, we're looking for evidence of edema, we're looking for any lesions. We check the dorsalis pedis pulse. If I get a strong pulse there, good. If not, I check the posterior tip. I check cap refill. So I've done my screening vascular assessment for follow-up. I'm not doing ABI on follow-up. I'm checking pulses, looking at the overall skin status, checking capillary refill. If that patient has been identified as having neuropathy, or if that patient is diabetic, and it's time for their sensory motor check, next I'll be doing my sensory motor check with the monofilaments and the tuning fork, and possibly my position sense testing. So I've done my vascular, my sensory motor if indicated, and now I'm going to inspect the foot and the nails. So typically I will start on the plantar surface and I'm looking for callus, I'm looking for lesions, ulcers, I'm looking for evidence of tinea pedis. Then I typically come to between the toes and I look between each toe to see if there's any evidence of fissure formation or tinea pedis. If there's a lot of debris between the toes, I'll take my little alcohol wipes or cotton ball soaked in alcohol and I'll wipe, discard, wipe, discard, wipe, discard until the skin is clean and I can assess. So now I've looked at the plantar surface, I've looked between the toes, I'm going to look on the tops of the toes for evidence of corn formation. If I see callus, I know I have to pare the callus. If I see corns, I know I have to pare the corns, plus I have to do something to protect against recurrence. If I see tinea pedis, I know I'm going to recommend topical therapy. If I see fissures between the toes, I'm going to recommend topical therapy. Plus, I'll probably use a little toe foam to protect the toe and to create some separation between the toes so I get better airflow. So I'm looking at the skin, corns, calluses, tinea lesions, interdigital spaces, and then I look at the nails. And initially I'm just doing a cursory surveillance, just looking to see how thick the nails are, how long the nails are, if there's any evidence of an ingrown nail. I'll once again ask the patient, any problems, any of your nails bothering you? Okay, now I need to look specifically to determine my free nail border. That tells me where I'm going to trim. So when I'm looking at my free nail border, I need either a spatula or an orange wood stick. We recommend spatulas because they're stainless steel, so we can disinfect them. Also, they're very flat, so they don't cause any discomfort. So what I'm going to do is I'm literally going to move the spatula under the nail, between the nail and the skin. And that tells me at what point does the nail separate from the skin. How much free nail do I have that might need to be clipped? So I wanted to show you a couple of things here. One of the things that sometimes happens, here you can see you've got your free nail border, so I'd be sliding my spatula between the nail and the skin, verifying my free nail border, making sure that I can easily slide my spatula. That tells me I'm going to be able to get my nipper underneath the nail, between the nail and the skin, follow it around to do my little nips to take off that nail. But sometimes you'll have what you see here. You'll have very thick callus formation running right up to the edge of the nail. And it's hard to tell where the nail ends and the skin begins. If there's callus, you always have to pare the callus first, so that you can clearly identify your free nail border. We never start clipping until we know exactly where our free nail border is. If callus obscures the free nail border, you begin by taking down the callus. The other thing I'm paying attention to is the thickness of the nail. So here, normal nail thickness, I already know I'm going to be able to nip those nails without any difficulty. But here I've got a combination of callus and very thick nails. So before I can even think about trimming those nails, I have to pare the callus, and I'm going to have to thin the nails. Then I can nip. Here, thick nails. I'm going to have to thin the nails before I can cut. In thinning the nails, I can either use my handheld rotary drill. If I'm not using a handheld rotary drill, I need a very thick emery board like you can get from Sally's Beauty Supply to take that nail down. We'll come back to that. Once I get ready to trim my nails, I'm going to take my nipper, and we'll show you more about this when you come on site if you come here for clinical. Most of the nippers that we use have a flat side and an angled side. The flat side always goes against the skin. That allows you to see what's between the blades, so you never accidentally cut the skin. So what I'm going to do is I'm going to slide the flat edge against the skin. I'm going to pull the skin away from the nail. I'm going to wedge the nipper in. I'm going to double check to see what I have between my blades, and then I'm going to take a small nip. And then I follow it over, follow it over, follow it over. So I basically follow the curve of the nail in trimming it off. A common question is, how do I know I got it short enough, and how do I know I didn't get it too short? In general, when you're trimming toenails, if I touch the end of the toe, I should touch toe pad before I touch nail. If I touch nail first, that tells me the nail's bumping up against the shoe. So I usually want to trim down until I touch toe pad first. How do I make sure I'm not getting it too short? I follow the free nail border. As long as I'm following the free nail border, I will not get it too short. Ideally, you trim fungal nails last because there's always the potential risk of causing cross infection. I don't know if that's a real risk or not because those nails sit side by side every day. So is that the most important thing? No, but I can tell you that if they ask you that on the certification exam, you say you trim the fungal nails last. And then once I've trimmed them, I'm going to take my emery board and I'm going to smooth the edges. I want to be sure I never leave a rough edge. Okay, so now I've trimmed my nails. Now what about corns and calluses? If they're very thin and not painful, they're not sensitive when I palpate, it doesn't bother the patient, then I can take an emery board and I can buff, but I don't go back and forth because that creates friction in the underlying tissue. I go in one direction only. Most of the patients you see, most of the clients you see, they'll have thick calluses, thick corns, and in that case, a better approach is to start with your scalpel and pare. And we'll show you how to do this, but when you're paring, you go parallel. So you start at the top of the callus or the top of the corn and you come across, come across, come across. So you can either keep it just even, parallel, or you can catch and lift, catch and lift. Sometimes you'll get to a point where you can literally scrape. What you never do is dig down and in. So you either stay parallel, catch, lift, scrape, scrape, scrape. But you never cut down. How do you know when you're done? Callus skin is going to look yellow and feel hard. So you're doing a combination check. You're watching for color change as the skin color starts to become more normal and as the softness returns. That means you're getting very close to normal skin and you should stop. I have not seen this written, but I will tell you that in our experience, some patients want you to take as much of the callus as you can because it tends to recur quickly and causes them a lot of pain when they're walking on it. Other patients will tell you to leave a little bit because if you take it all the way down, they find that more sensitive. So I usually ask my client, do you want me to take this callus all the way down or do you want me to leave a little bit? They will usually tell you. The other thing, of course, as we talked about when we went through pathology, if I have callus formation, it tells me that that patient's getting a lot of friction and shear and that I need to look at insoles and maybe send them to an orthotist. I will also tell you that there are some companies who make very thin glycerin gel pads and that can be helpful in preventing recurrence of the callus. They can put it on and then pull their sock over it. The sock holds the gel pad in place. Also, we'll tell patients go get either a very long emery board or a pumice, and 2 or 3 times a week after your shower, after your bath, then use your emery board or your pumice to file that down. Then the last thing we do after we have everything done, and this isn't essential, but it's very, very nice for the clients and makes them, is another thing they like about coming to you, is take a good quality lotion and massage their feet. You don't put it between their toes, just on the skin. We're going to spend just a few minutes talking about specific problems. I'm going to walk you through the pathway, but of course you're going to have to do this. So when you go to clinical, you'll get to actually do this. Hypertrophic nails, those very thick nails, the ones that you would never be able to cut with a nipper. What are your options? Well, you can thin it with a rotary drill, very effective. Of course, you're going to be wearing a mask and a shield. If you have one with a suction device, a little vacuum device, great. That is the fastest, most effective way to deal with hypertrophic nails. So you'll see that a lot of clinicians do use the handheld rotary drills to thin those nails down, then they can cut them. But if you're in an inpatient facility, of course, you would never do that unless you have clearance from infection control because you're worried about aerosolizing possibly fungal dust. So in that case, you would use your heavy-duty emery board and file it down as much as possible. The other possibility, if you can get 3-way solution from a podiatry supply catalog, 3-way is a softening solution, so you can take cotton balls, soak it in the 3-way, put it over the nail, let it soften a little bit, and then sometimes you can take your nippers and you can literally cut from the top down. So, handheld rotary drill, thick emery board, or soften and nip from top down. What if you have fungal nails and the patient's concerned? Well, you can teach them to apply some type of topical antifungal. a menthol-based chest rub, clear nails, whatever, along the cuticle, either every day or according to manufacturer's guidelines. The patient's very concerned, you can send them to a podiatrist or to their primary prescribing physician for systemic. Probably the most difficult problem is ingrown nails. Now you remember that any patient who has these C-shaped nails is at risk. So I look at this patient's at risk. But I also notice that at this point, this patient's really not having any problems. There's no redness, there's no tenderness. When you have a patient who is at risk for an ingrown nail, but the nail is not causing a problem at baseline, there's two schools of thought. One thought is just allow the nail to grow out longer than the toe. So just allow it to keep on growing. And once it grows out past the toe, just cut the distal end, that very clear nail border, free nail border, but never cut it down level with the skin. Make sure that it stays longer than the toe, a little bit longer than the toe. And the thinking is that as long as the distal end of the nail extends out past the nail grooves, the nail folds, that you probably won't get into trouble. So that's one option for a patient who has a tendency to an ingrown nail. They have those C-shaped nails. Now, if the patient comes in and they're having pain, and a lot of times they're already having pain, so they come in, they're like, something's wrong on this big toe, it's killing me. And you look and you see that they have that C-shaped nail, and you see that the nail is growing down into the skin, and that when you palpate it, it's sensitive. If you see that, so they're having pain, or you see clear-cut evidence that they already have some tissue inflammation and infection, then no, you can't just wait for it to grow out past the end of the toe. In that case, what you have to do is you have to wedge your nipper under the edge of the nail, and you just take your time, do it slowly, slowly, slowly. Your goal is to literally get under the edge of this nail, to slide your nipper up under here, to clip off the section of the nail that's causing the problem. Clip it off, smooth it down with the file so it's not growing into the tissue. And then extremely helpful to take a little piece of cotton or a little strip of an alcohol wipe and to literally place it, wedge it right under the corner. And again, you'll see that when you go to clinical. So if you have a tendency to an ingrown nail, you're at risk for an ingrown nail, but at this point in time, there are no issues, no pain, no tenderness, no redness. One option is let it grow out longer than the toe, and keep it longer than the toe, and keep it just trimmed and filed so that it can't grow into the tissues. But if it's already causing pain, if it's already growing into the tissues, then you have to lift out the corner that's compressing the tissues and causing pain. Lift out the corner that has ingrown into the tissues, smooth it down, and put a little packing. That packing acts as a spacer. So people are like, well, how long do you leave it there? Well, ideally until they come back. I hope when they come back to clinic, that little piece of alcohol wipe is still there. And then people are like, well, is that safe to leave it there? Yes, this is not a wound. I'm not leaving packing in a wound. I'm literally putting something between the skin and the nail. And that little strip of cotton or alcohol wipe simply separates the nail from the skin, so that when the nail wants to grow down, that little piece of cotton or alcohol wipe keeps it from doing so. We call it behavior mod for badly behaved nails. Can make a huge difference. So we're going to finish up by talking about patient education guidelines, referral guidelines. These are the things you know, but patients don't always know, so you want to talk to them about drying well between the toes, applying emollients after bathing, but only to the skin on the top and bottom, not between the toes, using the pumice to keep callus reduced, and emphasize, no bathroom surgery. It's amazing what people will do because, of course, they've taken care of their nails all their lives. They probably don't have anybody else to do it, and it's driving them crazy. So they're trying to cut that nail, but they can't see, or they can't get down there. So we've had people come in who cause a lot of trauma, a lot of bleeding, a lot of pain by trying to do their own nail care. So no bathroom surgery. Particularly important to emphasize for patients who have reduced sensation, who have any kind of impairment in perfusion, who can't see well or can't reach their feet. And we're always talking to patients about the importance of properly fitted footwear. You always have a list of places where they can go to be fitted correctly. Here's the guidelines for properly fitted footwear. If you have a patient who has normal sensation and no deformities, even if they have diabetes, they can buy their shoes off the rack because they don't have any deformities and they have perfectly normal sensation, so they'll know if their shoes are too tight, they'll know if their shoes are too short. So they just have to use intelligence when buying shoes, which is what we should all do. So first of all, make sure it's comfortable. Don't tell yourself that, you know, it'll stretch out or whatever. If it's not comfortable in the store, don't buy it. Walk in the shoe in the store to be sure your heel's not slipping up and down, that it doesn't feel uncomfortable. Very helpful to do that tracing. Tell people, buy your shoes at the end of the day when your feet are more swollen. Take a tracing of your foot, make absolutely sure that when you put the shoe on top of the tracing, the shoe covers the tracing. Otherwise, you know your foot is being compressed. The best way to check for fit is to take your thumb and your middle finger, put your thumb right over your bunion bone, okay? The medial aspect of the first MTP joint. Put your fifth finger or your third finger over the bunionette bone, okay? The lateral aspect of the fifth MTP joint, okay? That's the widest point of your foot, and it should correspond with the widest point of the shoe. If the widest point of your foot does not match the widest point of the shoe, don't get it. If you make sure that you have a match between the widest point of the shoe and the widest point of your foot, you almost always have enough room for your toes. But when you're walking, pay attention to what your toes are telling. Okay, what about a patient who has intact sensation? They have some deformity. So maybe they've got some hammer toes, but they have intact sensation. Maybe they have some callus, maybe they have a bunion. So you go through everything we've already gone through. Buy your shoes at the end of the day. Take time, don't buy them in a hurry. If they don't feel right, don't buy them. If the widest point of your foot does not match the widest point of the shoe, don't buy them. Also, for people who have hammer toes or overlapping toes, they have to buy shoes that have an extra depth toe box. So the toe box is, of course, the section of the shoe where the toes sit. And if I have hammer toes or overlapping toes, I need more room top to bottom. So you've got to make sure, and again, you can sit the shoe beside your foot. And if your toes are sticking up higher than the shoe, don't buy that shoe. And if you put the shoes on and walk in them and you can feel your toes rubbing, don't buy that shoe. For patients who have bunions or bunionettes, they're going to need extra width So they need the shoe that gives them extra width, and they might have to go someplace where they can get a shoe that's sized correctly at the level of the bunion and bunionette bone and also fits the heel correctly. The other important thing for the patient with a bunion or a bunionette is to have either a leather or a soft fabric upper that will give. No plastic, nothing rigid. Patients who have plantar surface calluses need padding on the inside of the shoe. They may need insoles. If they have problems with recurrent callus, they probably need to see an orthotist or a podorthist to get the correct insole. What about the patient who has compromised sensation? So they've got some loss of protective sensation, or they have severe deformities. Maybe they have a Charcot foot. Maybe they have a claw foot. They cannot buy shoes off the rack. They have to be professionally fitted, or they're going to have major problems. So we should be referring them. We should have a list of places they can go to assure that footwear is correctly fitted. Many of these patients, they'll actually have to make a mold of their foot, and then they'll have to modify the footwear accordingly. Patients who have fixed bony deformities like Charcot foot, those shoes have to be molded for them, okay? So otherwise they're going to get worse problems. Absolutely critical. Patients with loss of protective sensation, of course you know all of these things, but absolutely critical to reinforce them over and over. You have loss of protective sensation. You cannot buy your shoes off the rack. You will not know that they don't fit correctly. Also, never, ever, ever, ever go barefoot. Never. So one of my patients is like, I never go barefoot, only inside the house. I'm like, okay, let's revisit the definition of never. So what I'm telling you is based on my testing. If your feet are out of the bed and approaching the floor, they should be protected. You shouldn't even be wearing soft bedroom shoes. You need bedroom shoes with a protective sole because you don't know what's in the carpet or on the floor. So the critical importance of always protecting their feet. Shaking their shoes out before they put them on because you could have something in your shoe that you didn't know about. Checking the bath water temperature, breaking shoes in gradually so you don't just buy a new pair of shoes and wear them to work. You wear them for 2 hours the first day. Any problems? Then you probably shouldn't be wearing them at all. Okay, you did fine with those 2 hours. Okay, the next time wear them 4 hours. The next time 6 hours. The next time 8 hours. And probably the most important thing, which is why it's in all bold, check your feet at the end of every day. Visually inspect them, get that little mirror out, look at the bottom of your feet. Hopefully you have a skin thermometer. You're looking for any areas of redness, any lesions, any areas of increased temperature, which tells you something is going on in that area. If you have an area of increased temperature, like it's 4 degrees Fahrenheit higher than the surrounding tissue, you've got to watch it very carefully. If it doesn't subside, you've got to be seen. So monitoring the status of their feet. Always protecting their feet, never ever exposing their feet to hot pavement, to whatever's in the carpet, to that glass you dropped on the floor. So always protecting your feet, always checking your feet. And we need to know what we know what we don't know when to call for help. So we should refer to a podiatrist if the patient has a very difficult fungal infection that doesn't respond to over-the-counters. Patients with painful ingrown nails almost always need to be seen by podiatry. And patients with bony deformities. So I've had patients who say, what can you do about that bunion? I'm like, well, I can tell you how to modify your footwear, what to look for when you're buying shoes. And I can take this little foam sleeve and cut it to protect your bunion when you're wearing your shoes, but I can't do anything about the bunion. That requires surgery. and you would have to see the podiatrist. What about a podorthist and orthotist? Any patient who needs professionally fitted footwear or professionally fitted insoles goes to the podorthist or the orthotist. They are so skilled at that. And a vascular surgeon for any patient with peripheral arterial disease, venous disease, whatever. What do you have to have in your toolkit to be able to do foot and nail care? Well, I think we've gone over it. The essentials are your monofilaments. You can literally go online and look those up and see where you can get them for the least cost. Tuning fork, 128 cycles per second is the tuning fork you want. Very helpful to have. A Doppler to do ABIs unless you're going to refer them to vascular or send them to a vascular lab. That's your other option. And then, of course, the critical equipment. You have to have your spatulas or orange wood sticks. You have to have nippers. You have to have emery boards. If you're doing level 3 care, you need scalpels to pare down corns and calluses. And you want to at least think about getting a rotary drill. So we've given you a very helpful podiatry supply, and the online address www.henryschein.com/footandnail. That's where we get our equipment, so we know they're very good. So in summary, you want to be very clear about who does what in your clinic or on your team. You want to make sure that before you give care, you do your assessment, and that you're constantly educating your patients and that you make appropriate referrals. Make sure that you have appropriate procedures in place to assure infection control. Know what you know what you don't know. Never, ever, ever, ever hesitate to refer a patient to ask for help and monitor your outcomes. Thank you very much.